And our next topic is going to be treating relapsed refractory myeloma. And it's a particular privilege for me to introduce Tom Martin, who is the reason I went into myeloma, because 15 years ago when I was a fellow at UCSF, he was my attending, and I'm forever indebted to him for his enthusiasm and interest in myeloma.
Wow, 15 years ago. I thought it was 10.
15.
Man, time flies. So I'm delighted to be here. Yes, I'm from California, but I'm originally from Connecticut. And I was kind of hoping that I was kind of hoping that the Yankees won the World Series and it would be the parade today. And I could go to the parade. Oh, well. So I'm going to talk about relapse and refractory myeloma. And the prior speakers really set the groundwork for us. So we have a few things that we're going to talk about, but a lot of it you guys have heard. I'm just going to clarify what we do for relapse and refractory myeloma. So, and I'm going to start with a case. And this is a real case. This is one of my patients. JB's a 57-year-old man. He presented with stage 2 IgG kappa multiple myeloma. He received, and we talk about alphabet soup all the time, okay? So it's RVD, Revlimid, Velcade, and dexamethasone as his induction therapy to take his myeloma from here down to a low point. He then went on to an autologous transplant to try to deepen his remission. He achieved a partial remission. His M protein was 0.5 at the end of that. He tolerated everything quite well. He had grade 1 neuropathy. He then was placed on maintenance. You're going to hear a lot about maintenance, so we'll talk about it later this afternoon also. At 18 months post-transplant, his M protein started to increase. And so that's the first signs of disease relapse. He was asymptomatic. He's a young guy, but we switched his therapy. At that time, we chose to go to Pomalyst, another IMiD, the second-generation IMiD, Cytoxan and dexamethasone, a triplet. We'll talk more about that in a second. And he achieved another partial remission. His M protein went back down to 0.5 again. And at 12 months post-POM, Cytoxan and Dex, his M protein was rising again. There's two features about this. One, his remissions are not lasting as long as they should. And we'll talk a little bit more as we talk about relapse and refractory myeloma. From the initial therapy, we would like people to be in remission for maybe 2 years, 3 years or more. That suggests that this is a slow-growing myeloma and a myeloma that we're going to be able to treat and hopefully control for quite a bit of time, hopefully 10 years or longer. At that time, he entered a clinical trial, and it was a clinical trial that we're doing together with Hackensack and with Ajay here. It was a new CD38 antibody called Deacetylase together with Kyprolis or carfilzomib and dexamethasone. He again achieved a partial remission, but even only after 6 cycles of this therapy, he had more bone lesions on his x-rays. So then we had to switch him to the next generation or the next clinical trial. And he just entered a clinical trial using a BCMA-targeted CAR T-cell. And he actually comes into the hospital this coming week to get his CAR T-cells. And with that, I want to talk about relapse and refractory multiple myeloma. Next slide. So here's a, thank you. Here's a typical myeloma disease course. Now, unfortunately, when somebody has active myeloma, they tend to have symptoms from their myeloma, and they need therapy. Like Irene was telling you earlier, people that have MGUS or smoldering myeloma or may not have active signs of disease, they don't need therapy, and we follow them over time. But eventually when active symptoms develop, we give therapy. We try to induce the deepest remission. We watch for how long the remission lasts, and then patients will go through multiple relapses, okay? And in fact, each time we give therapy, we call it a line of therapy. And I want to define this, that a line of therapy is really when you get therapy to knock myeloma down, and then you have to switch either because the myeloma is increased or because you couldn't tolerate that treatment. That's the next line of therapy. And we kind of define what treatment we're going to give to patients for relapsed and refractory myeloma based on how many lines or how many prior treatments people have had. Now, unfortunately, the majority of people at this day and age still relapse from their myeloma. There might be 10 or upwards of 20% of patients. And hopefully there's some in the audience like that today, that the myeloma goes down and it never comes back. And that'll be great. And hopefully over the next 10 years, the percentage that happens is really going to increase. The other thing that I want to bring about that we haven't talked much about it is that somebody asked, what does multiple myeloma mean? Well, I say there's many definitions to multiple myeloma, but the truth of the matter is when patients present with myeloma, they already have multiple different types of clones right from the beginning. And I say it's like identical triplets, quadruplets, et cetera. When they're born, they look the same, but by 6 months, by a year, they're all acting different. Same thing with myeloma cells. And in fact, some may be sensitive to therapies and some may not be sensitive to therapies. So in this example, we treat somebody, the majority of their initial clone at the top of the slides are blue cells. We get rid of the blue cells and what comes out is these resistant cells, the red cells. And we start a different therapy. And we treat that red therapy, and perhaps on the left at the bottom, what comes back now is green cells. And green cells may have been back, they probably were there at the beginning. And they lasted through 2 rounds of therapy and then started to grow. But the clones are different, and that's why for patients who have been at this for a while, for 3, 4, 5, 6, 10 years, your doctors may go back to therapy that you had before, because sometimes that clone that's sensitive to a prior therapy will come back, and if you go back to that therapy, it might work. We call it somewhat of a ping-pong approach. We might give an IMiD at one point, and we might give a proteasome inhibitor the next point, and we might go back to the IMiD and then back to the proteasome inhibitor. And so we do this, we come up with all these different regimens, and I'll tell you some about the alphabet soup of regimens. So we have quite an armamentarium now of medications, and I like to break them down into blockbuster drugs and what I call backpack drugs. Blockbuster drugs are drugs by themselves, as single agents, can have really good activity. And those are the IMiDs, the proteasome inhibitors, like Revlimid and Pomalyst, Kyprolis, Ninlaro, Velcade. And the only other drug that's really a blockbuster is, at the current time, is Darzalex, or Daratumumab. That's a monoclonal antibody, an immunotherapy. All the rest of these drugs on this screen, except for the far right, those are being tested, are backpack drugs. They have to work together with an IMiD and really need to be in combination. So, when anybody has relapse disease, I like to say that it's really a personalized choice between you and your doctor of what your next therapy is going to be. And in fact, at our table here with maybe Dr. Gabriel and Ajay and myself sitting here, and you came to us at different 5-minute intervals and said, what treatment would you give? We might all say a different treatment. Okay? And I say myeloma treatment is an art. And it depends on what the duration of the first remission is, on the way I decide what your next therapy is. It also may be by your cytogenetics or FISH. Do you have high-risk disease? What's the prior treatment history? Is there an intolerance to Revlimid? If so, then I'll go with a proteasome inhibitor. Is there a lot of neuropathy? If so, maybe I won't use Velcade as part of the therapy. So again, myeloma is like art. That's why I always wear this tie when I talk to patients. It's an art, okay? And you have to go to an artist. And I would say the guys at this table here are all artists. So in New York, you have a ton of artists in here. You have a lot of museums. That's why there's so many artists. Go to a myeloma specialist, okay? You've heard that many times today. So I'm just going to define it for you. Thank you. And that is, so what we call early relapse is if it's going to be either your first to your third treatment regimen, okay? Late relapse is when you've had more than 3 prior lines of therapy. And we have these terms, double refractory. That's when you're refractory to IMiDs and proteasome inhibitors. And now we have this term pentarefractory. And that's when you're refractory to all the blockbuster drugs, including Daratumumab. In people in that scenario, I will tell you, like my patient, are best served by going to the clinical trials. We all here do clinical trials because we think we can do it better. I want to do it better than Ajay. I want to do it better than Irene. And they want to do it better than me. They're going to come up with great trials, and so am I. So join a clinical trial. I also want to just show a couple things, and that is, so when we talk about relapse, we also look at, the duration of the remission. And how long the remission lasts will really kind of give us an idea of what treatment strategies we're going to look at. On the far right, if you have less than 12 months of remission, that's really a bad prognostic group. And so we're going to do triplet chemotherapy or triplet therapy. Sometimes we're going to use back to intensive chemotherapy or a stem cell transplant if you haven't had a stem cell transplant. And certainly a clinical trial is a good option. If your remission has lasted more than 12 months, we have many different options. For what I call the early relapse, the 1 to 3 prior lines, we have a lot of different triplets, and we're going to talk more about that in a minute. So you've heard about, Irene has mentioned quadruplets, putting 4 drugs together, or triplets or doublets. This is when we put 2 or 3 or 4 drugs together. These are common doublets and triplets. For relapse disease, in every clinical trial, a triplet has pretty much won over a doublet, okay? And so if you can take 3 drugs, if you're strong enough and you're healthy enough and your kidneys are good, liver good, et cetera, then a triplet is probably better than a doublet. And so we try to do a doublet. And we have this alphabet soup that we can use for triplets. We have RVD, we have KRD, we have ERD, NRD, IRD, DRD. We have all these things. And we can talk about these with you in the clinic. And there's so many options that's why I say it's personalized care. We are really defining the regimen based on you sitting in the chair in the room, which is I think how we all practice. Okay. Now I want to briefly go over some of the new drugs and tell you just a little bit about each one of the drugs, so you have a familiarity about those. Now, when somebody comes to my office and we're talking about drugs, the first thing we're going to talk about is really, honestly, is convenience. Do you need a regimen that's convenient? Meaning, do you need an all-oral regimen? Do you live far enough away, or do you have a disability that you cannot get to clinic as frequently? That way you have to have you come back once a month. Once a month we can do with an all-oral regimen. Or do you live close by and spending some time in clinic? Maybe a weekly injection, is that okay? Or maybe twice weekly IV, can you do that? Can you come in San Francisco, we have to come across bridges. Can you come across bridges? Here too, you guys got to go across bridges, crazy. Sometimes the bridge is dose limiting for some of these things. So the first thing I ask, okay, is how convenient does the regimen need to be? And then we talk about the different potencies of the regimen. And that's what we're going to talk more about here with the individual agents and then in the next few slides. So there is now, the proteasome inhibitors have been either by injection under the skin, subcutaneous injection, or by IV. But now there's an oral one. We call it the oral Velcade, but it's actually given a name. It's called Ixazomib or Ninlaro. And it's nice. It's given once a week, 3 out of 4 weeks. Now, there is some toxicity to all of these. For this one, the most common toxicities tend to be GI. Mostly it could be nausea, it can be diarrhea, sometimes constipation, and sometimes a rash. Most of the time the rash is not so bothersome. It does infrequently cause neuropathy, but certainly a lot less than Velcade. And for some patients that have Velcade-induced neuropathy, I'll put them on the Ninlaro or Ixazomib, and they're actually able to tolerate it without progressing with their neuropathy. It's combined very nicely with Revlimid and dexamethasone. It's a nice triplet of IRD. I'll show you some data in a minute on that. Now, immunotherapy has certainly come of age, and we have 2 monoclonal antibodies. They're called naked antibodies that we use. This one, ELOQUENT, also known as Empliciti, is given weekly for 8 weeks and then every other week. The first time you get it, there's a 10% chance of an infusion reaction. After that, there's really little chance of an infusion reaction, and it's tolerated extremely well. In my mind, I have many patients that are getting elotuzumab at the current time and do not have a side effect from elotuzumab. Their side effect is sitting in the clinic once a week or once every other week getting an hour's worth of a medicine. That's the side effect, is being in clinic. Now, it also is combined with Revlimid and dexamethasone. So ERD is a really good regimen. The next one I want to tell you about is carfilzomib. Carfilzomib is a proteasome inhibitor. It's given IV. Typically, it's 2 days in a row, 3 weeks in a row, with the 4th week being a rest week. Now, more recently, there's been a clinical trial where they've combined the dose and given a bigger dose just 1 day a week for 3 weeks out of 4 weeks. And it looks like that's actually just as effective, potentially even more effective than the twice-a-week dosing. But perhaps there might be some side effects, including many people get high blood pressure from it. There's also some GI toxicity, some nausea, sometimes some diarrhea. But really what we have to watch is for fluid gain, cardiac side effects, and blood pressure going up. And often if somebody has high blood pressure, we have to increase their medicines. But otherwise, it's a very effective regimen. Again, this can be given by itself. It's a blockbuster. Or it can be combined with Revlimid and dexamethasone or Pomalyst and dexamethasone. Very potent regimen when it's combined with Pomalyst and dexamethasone. Now, the last one I'll tell you about is Darzalex. Now, Darzalex is the new one, Daratumumab. It's an anti-CD38 antibody. It's also a blockbuster, can be given by itself or in combination. This one takes a little bit longer in clinic. The first infusion, there's a 50% chance of an infusion-associated reaction. So it's real. So half of the patients are going to get an infusion reaction. Most of the time it's kind of stuffy throat. You kind of have to cough. You feel like some people can get short of breath. Sometimes you can have hives, sometimes fever, sometimes really significant nausea. And about a third of the time we have to stop the infusion, give more medications to kind of ameliorate the reaction, and then restart the reaction. 90+% and 99% of the patients can actually finish the reaction. It sometimes takes 6, 8, or 10 hours for the first day in clinic, but subsequent infusions will go faster, more like 4 to 5 hours. And after the first infusion reaction, typically you don't have subsequent reactions. Your blood level is very high. Getting more medicine usually won't induce a reaction when you already have a fair amount of it in your blood. Very potent, and other than, in my mind, the infusion reactions, very few side effects. Sometimes you can have some count suppression. We have to follow your blood counts. And this can be combined with Revlimid, Pomalyst, or Velcade. These are all approved indications of this drug. A very potent combination when you combine it with the IMiDs, or even with, in our clinical trial, with carfilzomib. Sorry, the last one I wanted to say, and this is just I'll say it is, Isatuximab is the other CD38 antibody. And Isatuximab is currently in a phase 3 clinical trial, and hopefully will be approved for use before I go gray. So, all right, so which to choose? Which combinations do you choose? You know, you need help to choose. And again, I can't stress it enough that this is personalized medicine. We take into account convenience, side effects, and also about efficacy. So I'm going to show some clinical trial slides. I know you guys want another clinical trial. Yeah, but I'm just going to go through it fairly quickly, all righty, just to give you a flavor for it. So these are phase 3. All these have been done in phase 3 trials where a doublet has compared to a triplet. And I'm really more going to focus on what's the remission duration that we can get. So progression-free survival here of about 21 months with IRD, with Ninlaro, Revlimid, and dexamethasone. This is Kyprolis, Revlimid, and dexamethasone. 26 months remission duration. So then when you get it as your first, second, or third line relapse, hopefully when you get on it, your remission is then going to last over 2 years, which is great. Hopefully it'll be even longer for individual patients. This is ELOQUENT with Revlimid and dexamethasone. Again, the progression-free survival about 20 months. So when you get on a relapse protocol and you're seeing how long your remission lasts, it should last between 1.5 years to hopefully 2.5 years. If you last longer than that, all the better. That means your myeloma is behaving very well. One interesting about ELOQUENT is that, in fact, if you look at patients that have achieved a similar remission, and this is basically ELOQUENT, Revlimid and dexamethasone versus Revlimid and dexamethasone, both of these groups achieving either a stringent CR or a complete remission, you actually do better if you get the antibody. We think the antibody is actually doing something special. It's probably boosting up the immune system, and it's probably inhibiting the regrowth of these cells. And so we do think that these antibodies help to keep the myeloma in check. So I do think in all of these regards, Triplets are better than doublets. Some of these new immune agents are really good. In fact, they boost your immune system and make the remissions hopefully last longer. Now, Daratumumab and Cetuximab, the other CD38 antibodies, they have a multitude of effects. And I'm going to tell you that they have direct effects on the myeloma cells, but they also have some effects on your immune cells that are sitting there in the bone marrow. And they may actually decrease the immune cells that are stunned or sitting there not doing anything, dormant in your bone marrow, and they may wake up some of the immune cells a little bit. And so that's a nice extra benefit of the anti-CD38 monoclonal antibodies. And in fact, if you look at some of the data, and this is Darzalex with Revlimid and dexamethasone, if we look at the progression-free survival in this one, it hasn't been reached by 24 months. People think it's going to be upwards of 40 months remission duration. That's the longest remission duration for a relapse trial. That's really exciting. And you have a really good one when it's combined in Velcade, but it's just not as long. It's more like in the order of 17 to 18 months. Okay, so which is best? The one that's best for you is the one that fits your side effect profile, your convenience profile, and also the one that hopefully is going to be the most active for you, okay? Now, second transplant is an option, but I personally say there's so many good combinations out there. I really reserve second transplant to one of my last possible options. After clinical trials, after anything else, I then will sometimes do a second autologous transplant. That's all I'll say about a second autologous transplant. Okay. Now, the other drugs that I'll briefly discuss, Pomalyst, it's the next generation Revlimid. The most common side effects are blood count suppression, sometimes blood clots, and rarely some GI toxicity. It's very good. It can be used by itself with dexamethasone and in combination with all the other agents that we just talked about. There's a histone deacetylase inhibitor, an HDAC inhibitor called Farydak or panobinostat. And in a small number of patients, I think a really unique patient population, it can be combined in Velcade, and we can see some synergistic effects of Velcade. Of all the drugs, this probably is the one I use the least, and because of the side effects. There are a lot of GI side effects, a lot of nausea and a lot of diarrhea. But it is an option if we need it down the road. And this is just the study from using panobinostat, Velcade, and dexamethasone, where progression-free survival was 12 months. So not as potent, I think, as the other three combinations. Okay. Now, pearls, we've kind of done pearls all along. My overall pearls is the three real potent classes are the proteasome inhibitors, the IMiDs, and the monoclonal antibodies. And your doctors will switch the combinations around to your benefit, and again, based on what your side effects are, what your prior history is, et cetera. Now, with the last couple minutes, I'm going to tell you that there are a lot of new drugs out there, okay? Our strategy has been ping-pong approach and to use this alphabet soup for a lot of patients with relapse. They get initial therapy with RVD or VCD. They get a transplant or they don't get a transplant. And then on relapse, they get these other triplets that we talked about. But at the end of this line here, or somewhere on the line, in my mind, it's a clinical trial, okay? How many people in the audience have participated in a clinical trial? Awesome. That's really awesome. Typically, it's about 5% of patients. I think you guys are more than 5% in this audience, which is really great. I tell my patients it's like getting frequent flyer miles. If you come to my clinic and you participate just by giving a sample or a bone marrow or a blood test, you get frequent flyer miles. I know you want to participate in research. I know the next best drug I have, you're going to be the person I'm going to ask you to participate in that trial because you're getting your frequent flyer miles, right? Everybody wants to go business class, right? You can only get there with frequent flyer miles. We're going to talk about just 2 or 3 clinical trial drugs. One is called venetoclax. Anybody in the audience have venetoclax? All right, we have a couple. So venetoclax is a BCL2 inhibitor, and in fact, in clinical trials, it's currently in a phase 3 randomized clinical trial. It's actually shown promise in combination with Velcade and dexamethasone. And it's a novel drug. We haven't had it. And there actually might be a biomarker. Patients that have an 411 translocation may have, 1114 translocation may have a better response to this drug. So if you have the 1114 translocation, bring it up to your doc. Hey, may I respond to venetoclax? It's a great drug in my mind in relapse disease. Next slide. Okay. So I wouldn't be giving you a talk about relapse and refractory if I didn't go over some of the future of immunotherapy. And I'm going to give you 2 or 3 small vignettes. Next slide. There are antibodies now. The antibody before was a naked antibody. This is an antibody called an antibody-drug conjugate, which you can see here that the antibody has a poison. This is a poison attached to it. So the antibody attaches to the plasma cell, and it brings a poison direct to the cell. These are targeted bombs. These are great. We have maybe 5 or 6 targeted bombs now that are going into clinical trial in the next 6 to 12 months. These, I think, are going to be way better than the current monoclonal antibodies that we have. The other thing is that we have antibodies. A typical monoclonal antibody, a naked antibody, has a binding domain up here that just binds to the myeloma cell. Well, this cell actually binds to the myeloma cell, and this arm is looking around for the immune cell. And it binds the immune cell, shakes it up, activates it, and puts it together with the myeloma cell. And if you look here, this is data from UCSF, from our scientists. If you look here, these are mice that the red means has a lot of burden of myeloma. These are mice that got placebo. These are mice that got these antibody, these targeted bombs. We can cure a lot of mice, which is great. Now we have to see if we can cure some humans, right? Next slide. The other thing is CAR T cells, right? We're all so excited about CAR T cells. We can take out patients' T cells. I call it the Marines. We can train the Marines in the test tube. We can give you some low-dose chemotherapy. I call it low-dose chemotherapy to kind of get your bunkers empty so the Marines are all out of the bunkers, and then give you back those Marines. And when we give you back those Marines, in fact, they work real well. If you look at the 2 slides on the right, in a bone marrow slide, the upper brown means myeloma, blue means nothing. These are 14 days later. All the myeloma in the bone marrow, gone. These are PET scans that are positive. A month later, gone. Next slide. This is really amazing therapy. It actually takes, it's very similar in my mind logistically like a stem cell transplant. It takes a lot of coordination. You have to have your T cells collected, you have to get some chemotherapy, you get infused the stem cells, and then in general you're in the hospital for 2 weeks to watch those Marines go to work. They go to work, there's side effects. There are fevers, there's chills, there's sometimes people can get a little confused. For myeloma, we really haven't had any deaths from toxicity. In other things like leukemia, the responses have been so great that some patients have died from too good of a response. And myeloma hasn't been that way. It's approved for use in leukemia. It's approved for use in lymphoma. It's going to work better in myeloma. Okay? Next slide. And I think with that, I'm gonna close with that and say it's always good to ask your doctor whether there's a clinical trial available. I told you about a few things that are available, but there's many other things that are available. Thank you for your attention. All right, I did want to ask one question. Are there any patients here from California? Yes, there's one from California.
Wait a minute. He's part-time.
He was part-time here and part-time there.
Exactly. So first, some definition question, which is remission definition, relapse, refractory. How do you define those, and are there any data to predict the time between those?
Yeah, so you guys have seen in prior slides, in the prior talks, that remission really is defined on how much the burden of myeloma has decreased. And once the burden has decreased, mostly by the assessment of the proteins in your blood and urine, by more than 50%, then you've achieved a partial remission. Okay, so most people with today's agents, especially, Irene told you about the triplets. Most people within 2 cycles are in partial remission from their initial therapy. Then when your proteins get to the lowest level, when they start to go up, it has to actually go up by a level of 0.5 to actually meet the definition of disease progression. And by light chains, it's up over 100. And so we follow those levels to meet the definition of progression. Now, often when the light chains or the protein goes up, often things don't have to change right then and there. Sometimes you can wait because, again, you're asymptomatic. But if the rate of the rise is always important for relapse disease. If it's going up real fast, then yes, we got to get at it. If it's going up really slow, we might be able to wait. We might be able to follow you before you need any other therapy. What was the last part of that question?
Refractory.
Oh, refractory. Refractory, there's very few people that are refractory at the current time from initial therapy. Refractory means that you haven't gone down by at least 25%. Now, in the relapse and refractory setting, so when you've had a number of therapies, when you get on one of these triplets, say your M protein is, you've relapsed, your M protein's 1, and you get on a triplet, and a month later it's 1, and in 2 cycles, a month later it's 1, and the third month it's still 1, you're saying to your doc, it hasn't worked, it hasn't worked. In fact, that might have worked, because your protein may be going up, but now all of a sudden it's stable. And so the treatment now has kind of kept things stable. And in my mind, when you get on a regimen, sometimes it's best to treat you with that regimen to the maximum possible benefit. The maximum benefit is for as long as you get it, and it's stable and not rising. You can sometimes, I've had patients that have been on therapy for 3 years where their disease has been stable. They haven't had a response, but it's been stable. And then after 3 years, when it goes up, we switched. Okay, so don't worry about it that it hasn't gone down. Sometimes that's actually a very adequate response.
And then the second question is cyclophosphamide or Cytoxan. Do you consider the use of that with either bortezomib or carfilzomib, a triplet? And when do you do that?
Yeah, so so alkylators, and the 2 ones that you guys hear about is cyclophosphamide or Cytoxan or melphalan or Alcoran, can be combined with proteasome inhibitors really well. So they can combine with Velcade and they can be combined with carfilzomib or Kyprolis. And that is those are triplets. So VCD or KCD, those are triplets, and those are common triplets. So in my mind, when patients are refractory to Revlimid and refractory to Pomalyst or pomalidomide, that's a great time to switch to a regimen like carfilzomib, Cytoxan, and dexamethasone is a great choice at that. That triplet's a great choice. And typically, once I get through the image or the proteasome inhibitors for the first round, I then go to either an IMiD or proteasome inhibitor with Cytoxan, with an alkylator-based therapy.